Great, sir. We have 81, 82 participants right now, 84. So we'll just wait exactly 5 minutes and then we'll take
Yeah.
the session.
Good evening, Dr. Ved. Hi, this is Monica. Hello. Hello, sir.
Mhm. Mm. हाँ शुक्ला जी, मैं कर दिया ना अभी निपले। अच्छा अच्छा, हाँ नहीं वो तो मैं अभी
When are we starting? Ved?
So we are starting in 2 minutes.
Gaurav, we will start in 2 minutes, na?
Okay.
Actually, we are waiting for someone. Actually, na? Mr. Sudeep is not there, so we are waiting for.
Who is Sudeep?
Mr. Sudeep is from Zygote Scoring, head of marketing head. I think.
Okay, okay. And Deepak Mishra is also from Zygote.
Yes, yes, sir.
And
Yes, sir.
Sahana
Yes.
Ray. You're
Sahana
also
is from
Zygote.
yeah.
Yes, sir. Yes.
Yes, sir.
Yes, sir. Do we start?
Yeah, we can start.
Yes. So very good evening to everybody. Welcoming all to the webinar session of simplifying embryology, how to select the best. So welcoming all delegates. So today we have with us Dr. Ved Prakash. I'll just request people to not raise their hands right away. We'll answer the questions because it has creates problem for the presentation. So yes, so today we have the coordinators, Dr. Ved Prakash and Dr. Sarabpreet Singh, and Zydus being the academic partner for this session. So just a small brief about Dr. Ved Prakash. So he's the lab director, South End Fertility and IVF, Delhi and NCR. He's a master in biotechnology, trained in IVF and ICSI from Embryology and IVF lab, KK Women's and Children's Hospital, Singapore. He also has a degree of advanced IVF, ICSI and embryo biopsy training at AZBU Brussels, Belgium. And he is the Vice President, Academy of Clinical Embryologists, India. So welcoming Dr. Ved Prakash.
Thank you.
Him, we have Dr. Sarabpreet Singh from New Delhi. So just a brief about him. He is MD from AIMS. He is the Senior Consultant and Chief Embryologist at the Artemis Health Institute since 2019. IFS and SRA Certified Senior Clinical Embryologist. He is the convener of IFS SIG Clinical Embryology from 2018 to 2020. He was awarded for Best Convener Special Interest Group at Fertivision 2018-2020. He was awarded the Champion of ISAR Award at ISAR Conference 2020. He was a convener IFS SIG Applied Genetics from 2020 to 2022. And his area of interest is cryobiology and male infertility. So welcome Dr. Sarabpreet and Ved sir. So I'll be handing over the session over to you. Welcome. So we can just start off with the session.
Thank you, Sahana, for nice introduction. Good evening, everyone. We welcome you all for this webinar, How to Select the Best. This is the initiative of International Human Embryology Research Academy, IHERA. IHERA is an online platform for all the embryologists, and we need a volunteer to join this. Whoever is interested, please join us. And this is our email. You can drop us an email on this info@ihera.org. As you all know that for the IVF success, we need a healthy live baby. For that, we have to select the best sperm, best oocyte, and after that, best embryo, which is going to implant and give a live birth rate. So, which is possible only when we will select the best sperm and best oocyte and embryo. So, which is possible only, in this webinar, we are going to learn to how to select the best. So we have Dr. Rahul Sen here, who is going to speak on how to select the best sperm. Dr. Rahul Sen is the Chief Embryologist with Vasundhara Hospital Limited, Jodhpur, Jaipur, and he is an executive member, Academy of Clinical Embryologists, ACE India. He is an executive member, ISAR, Rajasthan chapter, IFS, Rajasthan chapter, and he is the organizing secretary for Embryology ISAR 2018, held at Jaipur in December 2018. And he is a member of ISAR, IFS, ACE, ASHRE. Over to Dr. Rahul Sen.
So, yes, it's.
Yeah. Am I audible?
Yes, sir. Yes, sir.
Yeah. So good afternoon, good evening, everyone. This onset, I would like to thank the organizers, Ved sir, Dr. Sarapreet, for giving me this opportunity to speak upon how to select the best sperm. In the upcoming slides, we'll be discussing about the physiology of natural sperm selection. We'll be reviewing about the available methods for the traditional and advanced available methods for sperm selection in ART, followed by evidences to conclude. It is already evident from numerous studies that sperm has its impact not only on early and later stages of embryo development, but also on the ART outcomes. So what makes this tiny little cell of so much interest? Spermatozoa originates from the process of spermatogenesis via a series of cell cycle events, which is almost of 60 to 75 days of 60 to 75 days and produced in millions, which makes it a non-limiting factor. Genetic uniqueness in each sperm provides a wide variety of phenotype. Now, the ultimate question that arises that during in vivo conditions, how that one single cell is selected and on what basis. So, uh, during natural reproduction, sperm faces a series of environmental changes from the male reproductive tract to the female reproductive tract, where where post ejaculation millions of sperms are ejaculated inside vagina, and only few thousands of healthy motile sperms enters into the uterine cavity, leaving behind the poor quality sperms and the other cells. With further capacitation and activation, only one single spermatozoa is allowed to fertilize with an oocyte. So that shows the female reproductive organ is highly selective and highly selective and excuse me, just a second. Screen is
So you
the
can
female
just.
reproductive tract is highly selective and only one spermatozoa binds to an oocyte. So now the question arises again, can we mimic the nature in ART? So the answer is yes. ART is equipped with various strategies of sperm selection and can be done with the assistance of semen examination, with the morphology examination, and further subjective assessment can be done via selection in viscous medium, and also through advanced sperm selection methods, which we'll be discussing in later in the slides. So semen examination remains the gold standard for male fertility evaluation. It is a direct indicator for functioning of male reproductive system. As per the WHO Manual 2010, abnormalities in sperm production or function alone or in combination with other factors account for almost 30 to 50% of all cases of infertility. The semen examination can be done via macro and the microscopic parameters, which is very well known to us. Semen is primarily composed of sperms, with the secretions from various glands, other cells, and anti-capacitating factors. Ejaculate produced under in vitro condition has the higher chances of risk of oxidative and osmotic damage. There is a desperate need to separate these active motile sperms, healthy looking sperms, from the above seminal plasma. So to separate these sperms, these sperms, there are the various strategies of sperm preparation methods, which is done via mixing of culture media and involves centrifugation. Classical sperm preparation methods are based on morphology, motility, counts, and these techniques are also very well known to us, such as the migration, swim up method of centrifugation, density gradient. And soon after the preparation, when we assess processed spermatozoa under microscope, there is a view something like this, where we achieve only spermatozoa which are healthy, highly active with the motility, and later can be used for the purpose of fertilization. And soon after the OCC assessment, sperms are dispensed nearby and gametes are then co-incubated and then observed for the fertilization assessment later. Uh, it is not always easy to get a good quality ejaculate or the sample. Sometimes the abnormalities in sperms can be there, and it can be then the sperms individual assessment has to be done, and it can be done by the shape, light, refraction, and motion pattern under the viscous medium. You can see in this video as the motility is very much reduced as compared to the semen which are there in the culture media. And this viscous medium decelerates spermatozoa, allows evaluation in tridimensional motion, which permits us for the detailed morphological assessment. And and soon after the selection of spermatozoa, it is injected into these it is injected to the center it is injected into the cytoplasm of an oocyte and then later observed for the fertilization. So that these traditional methods of sperm selection are has as few drawbacks, that are these techniques utilizes centrifugation steps, which exposes healthy sperms to high level of reactive oxygen species and cause oxidative damage to the sperms. Sometimes poorly washed uh, sperms from the seminal plasma, and the selection of spermatozoa is totally based on motility morphology while neglecting other important factors such as DNA integrity, subcellular structures, and the lively cells. So that gave an advent to the introduction of advanced sperm selection techniques, and these techniques are introduced to assess spermatozoa with the specific features and are as follows. The first to go is the IMSI, that is the intramorphologically selected sperm injection, which was introduced way back in 2003 by a group of researchers. And it was introduced with the aim that high power differential interference contrast optics, and that allows visualization of sperm at ultra high magnification in real time. So this fine morphological, so this gave a strict descriptive criteria for the normal shaped head, and with this criteria, the head should be of smooth, oval shaped symmetry and symmetrical, and the nucleus must be homogeneous, no extrusions, no invaginations, maximum of one vacuole, less than 4% of the nuclear area. Is my presentation work? Yeah. There was an interesting article published in European Journal which studied semen analysis correlation with the IMSI outcomes. And the findings suggested that IMSI procedure may be more efficient in severe compound sperm pathologies than in patients with one abnormal semen parameters. Later, a meta-analysis published in a Chinese journal which reviewed 280 articles, 8 RCTs, and almost of 1700 IVF cycles, and that concluded with the evidence of low quality and showed that there is no sufficient use of IMSI in routine IVF with the male factor infertility. Later, it was reported again in Cochrane that the quality of evidence was low and suggested using IMSI of using IMSI instead of ICSI in clinical practice. Another technique which is the PIXI, which has another technique is the PIXI, which is in the process of fertilization. In the process of fertilization, sperm has the affinity to bind to hyaluronan. The pixie dish is a dish similar to ICSI dish that contains microdots of hyaluronan hydrogel. This selective binding shows the sperms, the binded sperms might have more viability, non-DNA fragmented, and with lower rates of aneuploidies. On the left of the screen, it shows a pixie dish, and onto this right side of the screen, you can see the spermatozoa, which few of the sperms are binded to this dish and few spermatozoa are still freely moving. Those which are freely moving are not the healthy ones, and those which are bounded and that can be used later for the purpose of fertilization. There was an article published in a UK journal and which studied a parallel two group randomized control study uh, to to assess the efficacy of PIXI versus ICSI for improving live birth rates, and it stated that PIXI does not significantly improve live birth rates. The wider use of PIXI therefore is not recommended at present. And later it was again confirmed in Cochrane, where this review was studied thoroughly with the two RCTs uh, showing the effects of PIXI versus ICSI with the live birth. Three RCTs were reported on the miscarriage rates, and four RCTs reported on the clinical pregnancy, and the quality of evidence was suggested to be low, and the technique was not suggested at all. The another technique, which is the max, another technique is the max, which selects non-apoptotic spermatozoa from the apoptotic cohort. There are the studies conducted on the use of max in ART, which are quite promising and providing good outcomes, but still large cohort studies are required for the clinical importance. Another technique, which is the microfluidics, that separates the motile sperm from the ejaculate by passive gravity driven devices, where the hydrostatic pressure of two separate inlets uh, drove media flow down the converging microfluidic channel. These are the few pictures of microfluidic devices which are commercially available. Microfluidics in sperm selection is an emerging technology enabling optimization of sperm preparation and analysis. The technology still has much to offer. Advanced sperm selection techniques are hypothesized to improve ART outcomes through the selection with the structurally intact and high DNA integrity. Although individual small studies have suggested that these techniques have clinical benefit, there remains less comprehensive studies. Currently, more studies are needed so that result can better guide clinical practice and further applications. Now, there, there may be few situations where customization can be done in routine methods of sperm selection that are dependent on retrieved sperm quality. One can be the total case of astenospermia. In this particular situation, it can be caused due to damages in motor apparatus of sperms, and the following tests like sperm motility stimulators, that is the use of pentoxyphylline, theophylline to enhance the motility and later used for the fertilization. Another is the hypoosmotic swelling test, where the sperms are allowed to mix in a solution of the differential osmotic ability, and then the sperm selection can be done. Later is the sperm tail flexibility test, and with the laser assisted immotile sperm selection. Another situation can be in cases of cryptospermia and leukocytospermia, where sperms are isolated in palate post centrifugation. There may be a lot of debris, other cells which may present in the that makes the retrieval of spermatozoa difficult. We can wait for the sperms to swim out, or mechanical isolation with the micropipette can be done thoroughly. And in cases of surgically retrieved sperms, the sperm preparation can be done by mechanical shredding, fine mincing, vortexing, or crushing of the testicular tissue, or the spermatozoa can be directly isolated with the use of injecting pipette. Washing and later rinsing in PVP can be done for the final selection. And the final selection is usually done in PVP. So to conclude this presentation, sperm preparation methods are still represent the gold standard for sperm selection in ART. In some difficult scenarios, customization in preparation methods can be applied. Although efforts have been made to develop more efficient techniques to select optimal sperm, data are still insufficient or controversial to conclude. Most of the novel methods are still not applied universally in ART. Their results are impressive as they tend to mimic physiological conditions. So, still in the current era of ART, what we mostly observe is the common routine sperm parameters, which are the counts, motility, and morphology. What is not explored or still hidden is the DNA damage, aneuploidy, or the abnormalities or the other abnormalities in the sperms. And these hidden parameters to be thoroughly assessed, and later can be later the sperm selection can be achieved for the healthy fertilization and outcomes in ART. So I'll end my presentation with a quote that the key is patience. You get the chicken by hatching an egg, not by smashing it. Thank you.
Rahul, very nice presentation. And now I hand over to my Dr. Sarapreet. He is going to introduce our second speaker. Dr. Sarapreet, unmute.
Okay. The next speaker is Dr. Paresh Mukwana. He is a ASRM certified clinical embryologist, and he is the chief embryologist at Wings Hospital, Ahmedabad. His key areas of interest are oocyte and blastocyst vitrification, IVM, and he has done more than 1,500 blastocyst biopsies. He's an executive member of ACE, India, and he's a lifetime member of IFS and also a treasurer in IFS Society Gujarat chapter. Over to you, Paresh Mukwana. Dr. Paresh, are you there?
Thank you so much, sir. Can you hear me?
Yeah.
Yeah.
We can hear you now.
Yeah. So evolution of the oocyte and cumulus oocyte complex. It is not working. Yeah. Why do we need it? Performing the right evolution of the nuclear and cytoplasmic maturation, it is very much needed in case of the in vitro fertilization. And we know that more than half of the collected oocyte during IVF, so at least one morphological anomaly that could negatively influence the embryo development. When there is high frequency of embryo demise prior to the blastocyst stage or after the implantation during the first 1 to 3 weeks of the embryo after embryo transfer, there is a chance of there is a possibility that inherent depend will be there, and it may be arise during the oocyte quality. So we have to look after the quality of the oocyte. In oocyte, there should be two processes should be synchronized: nuclear maturation and cytoplasmic maturation. We know that we can check the nuclear maturation by denuding the oocyte and checking for the polar body, but for the cytoplasmic maturation, we have to be hypnotized using several morphological criteria based on the cytoplasmic characteristics. Yeah, what is oocyte? It's a female gametocyte or germ cell, and it also carries the set of chromosome, contribute half of the set of chromosome contributed by the female, and it creates the right environment for the fertilization and also provide nutrient for the embryo till it will be sink into the placenta. See, in oocyte, this one is a corona radiata, this is a zona pellucida, this is a peritoneal space, and this is a vitelline membrane. So to work with the oocyte, what are the general rules? We have to maintain the pH and temperature. We have to maintain the pH 7.2 and temperature should be 37 degrees Celsius from we collect the oocyte from the follicular fluid to the embryo culture. If there is a slight change in the temperature, you will find the that depolymerization on the spindle. You can see here, if you only changes in the temperature for 1.5 minutes, it will lead to the depolymerization. It is a reversible process. After 20, if you keep it for 20 minutes for 37 degrees Celsius temperature, it will repolymerize, but the density of that microtubule decrease, and which may lead to the aneuploidy. So we will first check for the evolution with cumulus cumulus oocyte complex. So what is cumulus oocyte complex? During follicular antrum formation, the granulosa cells is differentiated into mural granular cells and the inner lining of the follicular wall, and corona cells, they are actually attached with the zona pellucida. And within this cumulus mass, corona cells in close contact with the oocyte develop cytoplasmic projection. It will cross the zona pellucida and it will come outside like a corona radiata cells. And this organized structure is called as the cumulus oocyte complex. Here we can see this is a immature oocyte. This these cumulus cells are completely compacted and enclosed. You can see here there is a germinal vesicle, and this oocyte is a mature oocyte, and it is typically surrounded by expanded cumulus corona cells. Although there is little bit correlation between the cytoplasmic maturation and nuclear maturation, according to alpha sensor code sensors, we have to document the expansion and non-expansion of the embryo oocyte. Oocyte denudation. Why do we need to denude the oocyte? To check for the nuclear maturation. We need to, and to check for the the morphology of the cytoplasm, zona pellucida, we need to denude the oocyte. Yeah. And what is the ideal timing for the denudation? We all know that the ideal timing should be around 39 to 40 hours, because in one of the article it is clearly stated if you do denudation around 36 to 36.5 hours post SCG, there is a chance only 58% of the egg will show spindle formation. But if you wait for the 39 to 40 hours, around 92% of the oocyte will show spindle formation. It will not. It doesn't mean if you wait for the 39 to 40 hours, that means it will increase the number of the mature oocyte, but it improves the fertilization and implantation rate. There is an article, we are using 80 IU per ml hylase, but if you use 8 IU per ml hylase, it is also efficient, and it leads to the high fertilization and development rate, and actually it's an economic alternative. we observed that waiting for 39 to 40 hours, it doesn't mean that you do the pickup around 30 hours and you wait for the 9-10 hours and then you think that there will be a cytoplasmic and nuclear maturation. But because it will not compensate the insufficient post-priming exposure to the follicular environment, and it is very necessary for the health of the oocyte. Here, after denudation, we check for the maturation. You can see it's a first one is the GV oocyte, the immature, M1 immature, and this M2. We only inject M2 oocyte which are matured. Oocyte morphology. So how what is the optimal oocyte morphology? It should be spherical in structure, clear cytoplasm. Then the polar body is non-fragmented, single polar body. That round and this zona pellucida should be clear, round and clear. When we have normal morphology of the oocyte, what you expect? You expect the beautiful blastocyst, and it is the 4A or 5A blastocyst. When it is a normal morphology of the oocyte, not going to happen every time, but you will have a beautiful blastocyst. The morphology of the oocyte, they are they are divided in shape abnormality, intracytoplasmic dysmorphism, and extracytoplasmic dysmorphism. We'll check one by one. Shape abnormality. There are more than 10 studies. Though there is a shape abnormality in the oocyte, there is no correlation with the implantation or fertilization, and there is no change in the cryosurvival. Here you observe in there is a oval shape oocyte. That oocyte it will fertilize and cleave normally, but the shape is different. But it is not going to affect the implantation. Here you can see the oval shape oocyte with the blastocyst already there, but it's a oval shape blastocyst, but there is no effect on the implantation. Because of this oval shape, there is a delayed development. Why? Because it probably due to a reduced number of cell-to-cell contacts. This is a giant oocyte. We never inject giant oocyte in our lab because you can see here there are the cytokinetic failure and fusion of 2G. Again, you inject with the sperm. There is a contribution to the diagenic triploidy, and there are many literature. If you inject this giant oocyte around the 200 micrometer size, lead to the that genetic defect. Now, cytoplasmic dysmorphism. There are intracytoplasmic and extracytoplasmic. In intracytoplasmic, the refractile body, SER aggregations, and presence of vacuoles. In extracytoplasmic, the first polar body, changes in the perivetal space, zona pellucida, and oocyte shape. Here you can observe the first one is diffuse cytoplasmic granularity. The second one is a centrally located granular cytoplasm. In third one, there is a SER, smooth endoplasmic reticulum. And fourth one is cluster of vacuoles. The first cytoplasmic granulation of the varying degree, we have observed during when we search the follicular fluid and that CO2 contain the blood clots, it is associated with the dense central granulation of the oocyte. And there is a negative effect on the fertilizers and blastocyst rate. We observed that many times in centrally dark granular cytoplasm, you get the blastocyst, but there is a fail of the implantation. The Kharaman and co-work in 2000, they observed there is a chances of the 50% oocyte are the aneuploid. See, this is a beautiful example of the the granular cytoplasm. You can observe this granularity. Found this is reached to the blastocyst, but the quality of the blastocyst is not good. Vacuoles. Vacuoles are membrane-bound cytoplasmic inclusion filled with the fluid. And these fluids are identical to the perivetal space fluid. When there is a small vacuoles around 5 to 10 micrometer, there is no biological consequence. And if the vacuoles is more than 14 micrometer, it decreases the fertilization rate, decreases the cryosurvival rate, and it increases the biochemical pregnancy rate. There are three types of vacuoles. The vacuoles which are already present during the oocyte collection, it may be due to the metabolic defect, and the vacuoles which are created by the ICSI. When you do ICSI, you inject PVP, it creates vacuoles, but those vacuoles are not detrimental. It will go away after 24 to 48 hours. And another is the very detrimental. The vacuoles around the later stage of the embryo, they are very detrimental for the blastocyst formation. You can see here, these are the small multipolar vacuoles, and here there is a big vacuoles. In both the cases, we got a blastocyst. but the quality of the blastocyst is not good. The blastocyst quality in both the cases is not good. And one more, this is a very good example. Here you can see embryo is fertilized, it's a fertilization, cleavage, and very good. And you can, if you are going to transfer on the day 3, you definitely transfer on day 3 because a very good compaction. But you observe here, they just the later stage the vacuole arise, and you just do observe what happened to my embryo. That embryo is completely degenerated. So later the stage of vacuole arise, it is detrimental for the embryos. Dark cytoplasm. When there is a dark cytoplasm, there is 83% lower chances of having good quality embryos. And there are many studies that it decreases the implantation rate. But in one study, in fertility study, there is no difference in lab and clinical outcome. In our observation, when there is a dark cytoplasm, dark oocyte, it cleaved up to day 3, and after day 3, you can find it's a degenerate the embryo. But it again, I would like to say it is not happening every time. Many times you observe when there is a dark ooplasm, again it's going to give you the beautiful blastocyst. Smooth endoplasmic reticulum. This is a very important factor. In metaphase 2 oocyte showing dominant aggregate, in first of the image you can find around 38.9 micrometer SCR, and in second is a 25 micrometer and 11.1 micrometer size of SCR. What are the predisposing factors? The duration and dosage of the stimulation is more common in short GnRH protocol, a higher concentration of the AMH and estradiol, and the appearance of SCR positive may be due to the ovarian hyperstimulation. Actually, in 2011, the Istanbul consensus, they have decided not to inseminate the SCR oocyte, and because in 2004, Otsuki and many authors, they have reported there is an early fetal demise in newborns with certain imprinting disorder. Here there is a SCR, but again this embryo developed beautifully and we got very good blastocyst. One more thing, SCR, actually the role of the SCR is the calcium release of the calcium. So what happened, you can find here the actual, in case of the SCR oocyte, the higher amount of calcium is released and the ATP level increased 2 to 3 times higher than the normal oocyte, and it creates a robust cytoplasmic effect. You can find there is a higher cytoplasmic vigorous movement and that is because of the SCR. There was a study by in 2013 by Metagill. They observed when they inject the oocyte with only SCR, they got normal babies, and it leads to that 2011 Istanbul consensus, they decide do not inject the oocyte. But after this article, they have reconsidered that you can inject the SCR oocyte, and in the 2017 in one SIG meeting, they have decided you can inject the oocyte, and decision to inject SCR positive oocyte should be reviewed by the clinical term, and it should be reviewed by the case to, it depends on the case to case. But it is advisable when you have many blastocysts, first you have to inject the blastocyst, first you have to transfer the blastocyst without SCR. You have to give priority to without SCR. But if there is no priority, there is not a single embryo without SCR, then you can go with the SCR, but you have to observe after the implantation and after the development of the baby. Now, what are the extra cytoplasmic dysmorphism? The change, the zona pellucida, you can see in first there is a thick zona pellucida, second normal, thin zona pellucida, enlarged zona pellucida, dark zona pellucida, and oval-shaped zona pellucida. But the darkness of the zona pellucida did not influence the fertilization rate, embryo quality, and implantation rate. The Ramaraju, Montague, and they have observed when there is a clinical outcome was found improved when oocyte with high birefringence of the zona pellucida. You can see the Dr. Marcus Montague, what they observe. This is called, they observe the oocyte with the poloscope, and it is very intense birefringence of the inner zona layer, and they call it a high zona birefringence. In this case, there is high chances of the implantation, but when there is low zona birefringence, there is a chance of the lower chance of implantation and miscarriage rate increase. Now, enlargement granulation in the PV space, that is perivitalian space. Mostly the large perivitalian space, they are considered as a maturity of the oocyte. It suggested that the presence of a large PV space is over maturity of the oocyte. When there is in the peritoneal space, if you find the cortical granules, they may be the correlated with the high dosage of the HMG. The Clemaio and Coworker, they found correlation between the size of the PV space, presence of granulation, and subsequent embryo quality, but not with clinical pregnancy and implantation rate. Here, in the first case, there is a large PV space. There is no effect on the blastocyst formation, no effect on the cleavage, and we got very good blastocyst. Here, in this case, there is a large PV space, but there is a cortical granules, and these granules are actually the remnant of the corona cells. Mostly, we have observed when there is a high amount of cortical granules, granulated in the PV space, we observe that
I think Parish's network might be.
Yeah, we are experiencing some bandwidth problem with Parish's side.
I think he logged off, so I just have to. We have to reconnect. His screen is visible.
I think sir is back. Yeah, he's there.
hello.
Hello.
Yes,
Yes,
sir.
yes, please.
Yeah, sorry, I was disconnected actually.
Yes, sir. Please continue.
Yeah. So Abner and co-worker, they found the strong correlation between the morphology of the polar body and the embryo implantation and fertilization rate. What they observe, actually what they did, they divided and they graded the polar body, grade 1, grade 2, grade 3, grade 4, where grade 1, there is a normal polar body, and grade 4, there is a huge first polar body. They observe there is a higher fertilization rate in grade 1 and lower fertilization in grade 4. But in case of the grade 1 polar body, the quality of the embryo was, the grade 1 embryos are a higher number of the amount of the grade 1 embryos. But in grade 4 polar body, they found there are only 80% of, around only 22% having the good quality of the embryo. Oocyte aging. Oocyte aging decreased the fertilization rate, polyspermy, parthenogenesis, and it retarded the development. To check for the aging of the oocyte, we have to do the polar body. We have to do the polar body of that polar body biopsy. Why do we need to the evaluation of the oocyte? The M2 oocyte morphology did not affect the fertilization, cleavage, and embryo quality, but definitely affect the implantation rate. So oocyte quality, it gives important information regarding to the subsequent development ability of the driving embryos, and it reduces the number of the inseminated oocyte. In some of the country like Germany, they can inject only 2 oocyte. At that time, they can select the base oocyte for the insemination. And in this, it also helps to avoid inseminating bad quality oocyte. It helps to choose the appropriate number of the oocyte in egg donation program. Thank you so much. So
Thank you, Paresh.
actually the dream of the embryology, we should have the 100% blastocyst, 100% implantation, and 100% take home baby rate. Thank you so much.
Thank you. Thank you, Paresh. Thank you for nice presentation. So we will take questions after the panel discussion. So we will start our panel discussion. Our panel discussion is on how to select the best embryo. So for that, our moderator is Dr. Ratna Chattopadhyay and Dr. Saraprit. I am going to introduce Dr. Ratna Chattopadhyay. Dr. Ratna Chattopadhyay is Chief Embryologist, Institute of Reproductive Medicine, Kolkata, and worked as a research fellow in Cleveland Clinic Foundation, USA. And she is teaching FNB students since 2002, working as a faculty in ART training program conducted by IRM since 1990, working as a faculty in ART training program conducted by IRRH since 2003. Total number of chapter contributed in national textbook is 6, and total number of publication in peer-reviewed international journal is 20. Over to Ma'am Dr. Ratna Chattopadhyay and Dr. Saraprit.
Thank you. Thank you, Dr.
Thank you.
Hello. Good evening, everybody. It's my pleasure to be a moderator of the panel discussion on selection of best embryo today. My co-moderator is Dr. Saraprit, a very dynamic and well-skilled embryologist of my next generation. Actually, he is the main moderator today. I am assisting him. And we have panelists. We are very happy to have panelists like Dr. Ved, Dr. Gaurav Majumdar from Delhi, Dr. Charudat Joshi from Indore, Dr. Sam Balu from Bangalore. And we are fortunate enough to have Dr. Yusuf from Abu Dhabi with us today. Dr. Yusuf, he is the director of Faki IVF Center in Abu Dhabi, one of the biggest ART center in Middle East. Moreover, he is the consultant of so many other ART center in Middle East. He's a known face in so many national, international conference. He has more than 20 publication and book chapter. He is specialized in time-lapse incubation, vitrification, quality management, etc. And I know I have seen his paper on morphometric analysis, and today we are very eager to hear from about the morphometric embryo selection.
Thank you very much.
Thank you. Welcome. And then Dr. Charudat Joshi is with us. He needs no introduction. He's a very good human being and pioneer, well-trained, well-skilled embryologist. He trained himself from abroad in assisted hatching, in PGD, in ICSI. Moreover, he is the maker of so many good embryologists of our country. He was the first president and vice president of Academy of Clinical Embryology, and now medical director of Genis India ART Bank. Dr. Saraprit, you please introduce the others. Dr. Saraprit,
Unmute.
please
Can you
introduce the
hear?
other panelists here.
So now I would like to introduce Dr. Gaurav Majumdar. He's a very dear friend. He earned his MSc in clinical embryology from National University of Singapore in 2001. And thereafter he received his PhD for research work in PGT for aneuploidy. He's the lab director of Sir Gangaram Hospital. In 2014, he successfully set up a PGS and PGT program. And he has been awarded the Economic Times Fertility Award for the Best Embryologist of the Year, 2019. He has got numerous publications, and he's the joint treasurer of ACE India. Next, I would like to introduce...
Thank you, Saraprit. Thank you
thank
for the
you.
kind intro.
Then I'd like to introduce Dr. Sam Balu. He's a molecular geneticist who has specialized in genetics from postgraduate level onwards. He is a PhD in human genetics and has a postdoctoral fellowship from NIMHANS, Bangalore. He has got more than 10 years of experience in the field of human genetics. He was a part of the PGS PGT domain at the MedGenome Labs right from its inception. and he played a key role in validating and developing the PGS test during using NGS technology. His current role is as Assistant Lab Director at Eurofins, Bangalore, and he coordinates clinical reporting operations as well as clinical genetic tests such as carrier screening, PGS, PGD, exome, and microarray testing. Sam, are you there? Sam is not there with us, but he'll join. Ma'am, I'm sharing my screen now. Please enable, please allow me to share the screen.
Yes, yes, sir, you can share the screen.
No, it's disabled.
I'll just, yes, just a minute, sir. Sir, you can share now. You can share now, sir.
Yeah, I'm doing it. So I will hand over the proceedings to Dr. Ratna Chattopadhyay, and she will take the first few questions. Ma'am, over to you.
Yes.
Is it visible? Everything is clear? The screen is okay?
Yes, sir. Yes, sir.
Yes, full screen. You
So
have
just
to
slideshow. If you could just make that fine.
Yeah.
start. Yes.
Yes. Actually, you know that the journey of embryo development from follicle to endometrium involves a series of critical and complex events, and it is impossible to pinpoint one particular event by which we can identify our golden or optimum embryo or blastocyst destined for implantation. And you know that the responsibility of the embryologist is not only to generate good number of embryos, but to select good quality embryos for transfer. So I am starting the panel with a question: why is there a need to select embryo, or what are the basic needs for embryo selection? To Dr. Charu, please.
Yeah. First of all, good evening to everyone, and thank you, Ratna Madam, for such nice introduction. So basically, in today's era, we have so many infertility centers coming up. There are already so many centers running, and the ultimate criteria is what is their take-home baby rate or the pregnancy rate they achieve. And that's why to achieve that highest pregnancy rate, we definitely need to select embryos before transfer. And nowadays there are technologies available which allows us to go for ACT, single embryo transfer, the best selected embryo with only transfer. And it directly depends on transferring, you know, if you select good embryos, then only you can expect good number of pregnancies out of it. And we select those embryos which follow a standard pattern of growth, which we will come across in upcoming discussion. But we usually keep on observing embryos nowadays continuously for their development and following the standard pattern of cleavage. And we have very well placed guidelines to correlate the development of embryo, and then on basis of that we can select. So basic question is why there is a need. Need is there because we want pregnancy.
Yes. So increase the pregnancy rate, we need it. And Dr. Yosef, just we like to hear from you.
Yes. In IVF cycles, we have many embryos forms for the patients. And we need to select the best embryo. Selecting the best embryo will help us to have a high pregnancy rate and have high pregnancy rate, and will help us to reduce the multiple pregnancy, and the genetic selection of embryo will prevent the transmission of genetic disorder to the offspring, and will reduce the need for fetal reduction in case of multiple pregnancy. So we have many features that we can use in the lab that allow us to include or exclude embryos for embryo transfer.
So the main aim is to select a viable embryo,
Yeah.
which is not only implantable, but healthy enough so that it can continue the pregnancy
Yeah,
and
yeah,
be able to give birth of a healthy child. And
Yeah.
moreover, we have to be confident enough to transfer only few embryo or one embryo to reduce the multiple gestation rate
Yeah.
and to avoid bad consequences of multiple gestation rate,
yeah, yeah.
so that we can proceed towards single embryo transfer. And another thing is that we can reduce the load of cryopreservation also, so that we can cryopreserve the only few good embryo, and we can, by this we can improve our FET, success rate, FET cycles.
Yes. In our center, we advise all the patients to have a single embryo transfer, and we free.
Question to you. Just wait.
We free only the good blastocyst on day 5 or day 6.
I will ask you. Just wait a little bit.
Okay.
Next one. Dr. Yosef, what is the most commonly practiced method of embryo selection in India or your country?
There are many methods for embryo selection, but the most common are the sequential chronological morphology assessment. This includes assessment of embryos after insemination at certain time intervals. In day 1, we are checking the fertilization. We are checking the presence of the 2 prenuclei and 2 polar body. And we look at the zona pellucida. We need to have intact zona pellucida and clear, healthy cytoplasm. After that, we go for selection on day 2. We are looking at the number of blastomeres, symmetry, presence or absence of fragmentation, and the multinucleation. In day 4, we look at the compaction, and in day 5 and day 6, we are assessing the blastocyst. We are looking at the expansion, the inner cell mass, and the trophectoderm. This is the most common. There are other techniques that are less common, but it's not used in the routine IVF practice.
This is the most common. Actually, the time point morphological evaluation is still popular because it is cost effective and easy to perform. So we have to concentrate on the number of blastomere, symmetry of the blastomere, on-time cleavage, then number of nuclei, percentage of the inner cell mass, trophectoderm, and the blastocyst expansion. Thank you. Now, next one to Dr. Ved, a very renowned embryologist. Though we are not practicing, but what are the other available techniques? We are not practicing in our day-to-day life, but what are the other ones?
Yeah, ma'am. There are many techniques available, like timeless imaging, where we are saying that morphokinetic, on the basis of morphokinetic, we are checking for the, we are selecting the embryo, and computer-assisted morphometric analysis, PGD, and artificial intelligence, oxygen level in follicular fluid, and perifollicular vascularization, and omics assessment of culture media, just like amino acid profiling, metabolomics, and gene expression in Cumulus cells and or embryo. But although these techniques are available, but I want to tell that most of the techniques are unaffordable, expensive, and most of the time the results are inconclusive. And their research shows that there is no significant improvement in live birth rate. So although these techniques are available, but routinely we are not using these techniques, as Dr. Yusuf said that in last slide, that we are only using morphology assessment by microscope.
Yes. Yeah. Gaurav is here. Gaurav, why the omics? It was a very popular or hot topic 2 years before, but now just it is not at all popular. Rather, we are discarding or we are not thinking about. What are the main reasons behind?
Omics.
It was very popular or rather hot topic before, but now we are not just picking it as a selection procedure of the embryo viability score.
Yeah, because initially when it came into the market, especially metabolomics, it showed a lot of promise, but with time there were studies which were performed and which evaluated the efficacy, the actual efficacy of all those platforms which utilize some form of omics. And they saw that the evidence was not there, which was supporting the value of using omics. And second, they saw that it was not even reproducible in different parts of the world. So that was a big problem. And to the extent that they actually withdrew the omics from the commercial market.
Yes. Expensive also. And the components are so labile that we are not getting the proper evidence.
Yeah.
Yes. And Dr. Ved or Dr. Charu, you have any idea about the proteomics or secretomics? Which one is still we are trying? Still there are some relevant studies. What the biochemical analysis you have any you can highlight?
Yeah, I have no personal experience about it, but definitely analyzing the metabolic activity fluid after the culture of embryo, definitely a field where a lot of things can be understood, and we can use them for selecting the embryo. But I don't have any personal experience of utilizing any of these methods.
Yeah.
This was mostly in the research setting.
Research
Not
setting.
come
Yeah,
into
yeah.
clinical
Not, not everyone is doing.
Proteomics, proper proteomics, you have to kill the cell to know the amino acid sequence. It is not worthy. But secretomics, particular factor or protein that may just dictate the ploidy status of the lipocalin 1 or these things. Yeah, I am also not very just known about this fact. Dr. Yusuf, just now you are just explaining about the single embryo transfer, but do you think that with current embryo selection procedure, we can practice single embryo transfer without compromising the success rate?
I think there is a chance for performing elective single embryo transfer without compromising the success rate. In my clinic, we do most of the patients single embryo transfer, and we do also most of the patient for PGS for 24 chromosomes. So if we have a good embryo that is able to reach the blastocyst stage, this means morphologically normal, and we check the 24 chromosomes. This means the chromosomal and genetic component is normal, and we have this embryo transferred. The answer is definitely yes. We can do elective single embryo transfer without compromising the success rate. But also we can have good benefits from this, as we mentioned earlier. We can reduce the multiple pregnancy, and we can give the patient other chance by freezing the remaining embryos.
Yes, in India, you know, I think Dr. Charu, Dr. Gaurav, Dr. Ved, they also just be same opinion they have because just most of the clinics. Gaurav, you like to say something?
Yeah. So, like Dr. Yusuf said, we were just doing a recent analysis of our work. So, in the last year, in 2019, we performed about 800 FETs in all. And out of those 800 FETs, 75% of the embryos which were transferred were single embryos. And out of which around 400 were day 5 blastocysts, and 200 were day 6 blastocysts, and 200 were day 3 embryos. So we saw that the pregnancy rates with single blastocysts was very high, and there was no form of compromise which occurred after transferring single blastocysts. And what was interesting is that in the small proportion, in about 25% cases where we did transfer 2 embryos, sometimes we transferred 2 embryos, 2 day 5 embryos, or sometimes we transferred 2 day 6 embryos, the increase in pregnancy rate was not very high. However, the increase in the multiple pregnancy was almost 30-fold higher. So this was very, very interesting evidence. We saw that actually we are not helping by increasing from 1 to 2 when good embryos are concerned. However, the multiple pregnancy is just going through the roof.
Yes, you are skilled embryologists, you have the facility of PGS, but so many centers in our country, they are flooded with patients having advanced maternal age, poor responders. Yeah. So to get good blastocysts is really challenging, and we have to have the PGS facility. So still probably we have to wait a little bit for this single embryo transfer. Probably, I have no idea. Now, Charu, please, which classification of embryo grading is followed at your center?
Yeah, this right now we are, I think most of us are follows Istanbul consensus, which is there. And but I would like to mention here that this process has gradually evolved. This has started 15 years back when people were having their own classification system, and we used to select the embryo and transfer. But then as this workload increased, the cases are increased, then it was thought that there is a need of a uniform this thing. So now I think this is the most possible way of selecting embryo and see the division stage. And morphology, as you rightly said earlier, morphologically looking embryo, only if you keep on observing morphology and development of the embryo, you can make a selection. All other techniques are not still that easily available to everyone. So Istanbul consensus clearly gives us this idea that at what stages you have to observe, and at particular time period what stage it should be. If it is not there, then you should consider it as a slow growing embryo or a grade 2 embryo. So most of the places I follow this Istanbul consensus only.
So just you can just
yeah, I would like to tell about this, that although it has shown that you need to see after for the fertilization check, then syngamy, then early cleavage and all, but to be very honest and practical, we cannot expose embryos so many times. Still, at most of the places I follow a PN stage observation, then I follow the early cleavage check, and then we straightway see on day 2, day 3, and then day 5 blastocysts. So they have given that after 18 hours post insemination, you should see for PN stage, then you see for syngamy in around 20 to 23 hours. Then at 26 to 28 hours, we see first cleavage. Then that cleavage should be equal blastomere stage, because you have to see the size and shape of the blastomere also.
Dr.
Then
Charu,
44, yeah.
Can we omit the early cleavage check in certain cases?
Yeah, like in ICSI cases, most of the places we usually do it like this, that because it's an ICSI case, so there is no need of even observing it for the fertilization also. We can see just for the cleavage also, but most of the places I prefer to do observation and then straightway day to this thing. We can omit early cleavage stage for ICSI patients particularly.
So your message to the beginner or the new embryologist that please check the early cleavage in time.
Yes, yes. Because there are papers, studies which shows that the early cleaved or properly timed cleaved embryo has more potential of implantation and give the pregnancy. So one should stick to this criteria.
Most powerful parameter, definitely.
So what is your recommendation for IVF cases? IVF cases.
Yes, IVF cases we have to see for the early cleavage because we don't know if the fertilization is abnormal or there is some sperm defect or something. So we should definitely see for early cleavage in IVF cases.
And fertilization check will be there. That is
Yeah. That is there. That is 100% there. Once you can omit in ICSI, but not in IVF. IVF you have to see PN.
Next one. Gaurav, you know that most problem or in morphological evaluation is the intra and inter observer variability. So how can we avoid this problem?
Yeah, well, that's a good question. And in our laboratory, we have a team of 4 embryologists who are working together. So in order to make sure that there is very little intra observer variation, we've made this as a ethos to always discuss, for the senior embryologist to discuss the grade which is being assigned to a particular embryo. So when embryos are seen under the inverted microscope, then for example, if blastocysts are being graded while freezing, we try to do the grading with consensus so that the senior embryologists can make sure that everybody is on the same page while a particular trophectoderm or a particular ICM is being graded, so that more often than not later, everybody starts following the same thought process. So according to me, this is the most important thing, that the grade has to be discussed in real time, and not just by looking at images, but while the selection is being done. So we do this as a routine practice in our laboratory.
Gaurav, you grade the blastocyst on inverted microscope or stereo zoom microscope?
On inverted microscope.
Inverted microscope. Oh.
Yeah. And you take pictures and your staff can be taught?
No, we don't take pictures. So if there are, so it's visible on the camera screen, on the big screen. Okay. And so while I am looking at the blastocyst in the microscope, the others are also seeing what I am seeing. So sometimes we also have a little bit of, difference in opinion, where I'd rather even ask for opinions of the others, to ask them that, what do you think the trophectoderm looks like? Because it's all very subjective at the end of the day. It is not an objective process. So sometimes I'd be like, do you think the trophectoderm looks good? Or do you think the cells look a little less in number? So we do a lot of consultation amongst colleagues while grading embryos, and which really helps.
Many times we are required to, turn the embryo with the help of pipette, that is possible only in a stereo zoom microscope, and then evaluate in a 3-dimensional fashion,
Yes, so when we take embryos under the inverted microscope, we always have ICSI pipettes ready to manipulate the embryo. So we otherwise never take embryos. So we mostly do this embryo. We assign grades on blastocysts on the inverted microscope. But for day 2 and day 3 embryos, we do it on a stereo zoom, because we don't want to expose them by taking them to the inverted microscope all the time. However, we have a lot of discussion, and when we ask people to write the grade, we ask them to be very specific, sometimes even draw the embryo, to discuss a particular feature of the embryo, so that I know that everybody is seeing what I am seeing and everybody is on the same page.
Yes. Yeah, but embryo can change its status markedly within few hours.
Yeah, that's true. That's true.
More observation.
Yes.
And without giving stress to the embryo, you know what is the solution, main solution?
Yeah. We don't have time lapse. Unfortunately, we don't have time lapse. So these are all strategies devised by us.
Again, it is difficult to afford by majority of the center.
Yeah.
So by good 3D microscope, by transparency, by good communication, and following Istanbul consensus, we can reduce this variability.
Yeah, we think communication is the key. Very, very important.
Next one, please. Dr. Ved, again, just why fertilization or is fertilization checking and zygote scoring is important in further evaluation, or we can omit this step?
Ma'am, usually we check for fertilization after post-insemination 16 to 18 hours. And the optimal fertilized oocyte should be spherical and have two polar bodies with two centrally located juxtaposed pronuclei that are even size with distinct membranes. And the pronuclei should have equivalent number and size of NPBs that are ideally equatorial aligned at the region of membrane juxtaposition. So in some countries like Germany, they are because of their legislation, they require embryo for culture to be selected at the zygote stage. So at that time, this helped them to eliminate embryo, which have limited implantation potential. So assessment of early parameters, day 1 and day 2, can provide a post-hoc indication of gamete quality. So when in these countries, they are basically what they are doing. They select the embryo on zygote score based on zygote scoring, and deselect the embryo which are not going to implant or which has limited implantation potential. There is a scoring system for that. We are mostly they are using. They divided it in 3 categories: like symmetrical, non-symmetrical, on abnormal. In symmetrical, the description is that similar PN is there, Z1, Z2, and non-symmetrical is the peripherally located pronuclei and other arrangements. And in abnormal category, there is pronuclei with 0 or 1 NPBs. These are the scoring system we mostly use. They are using, and I think in like in our country, we are just checking the 2PN. That's why that is what I am doing in that. For that pronuclei NPBs, we are not so much. We are not doing too much in that in our country.
Yes. It is an important step.
But we are checking just good or bad in this. If it is good or symmetrical, good symmetrical, then we are selecting as a good. And if not symmetrical, we are deselecting or we are keeping them separate. But that's what we are doing in that.
Yes. So to assess fertilization first, and then definitely fertilization, or just to assess the failed fertilization rate, we need it. And
yeah, we need it. Yeah.
Over the zygote scoring, which in association with the second evaluation of blastocyst may represent a major step towards single embryo transfer. It helps us.
Yeah.
Definitely.
Yeah.
Yes. And what about the other findings? Yeah, please next. The positive, just mention some positive and negative findings of a zygote. Which one is good? Which one may be bad?
Ma'am, we generally don't do zygote scoring.
Yeah.
We only look at the PN status.
PN status, yeah, right.
That is zygote scoring.
Yeah, which is our only intention is to segregate the 1 PNs and the 3 PNs from 2 PN.
You are right.
But one thing that we look for is the first picture that you have put is the PN are not juxtaposed to each other. They're not abutting, but they're far apart. This we have seen. So earlier, many years back, in the beginning, we used to, grade embryos on the basis of the NPBs and all the symmetry and all of that. And there we have seen that these are the embryos which don't do well, where the PNs are far apart.
Chromosomal abnormality that signify the centriole defect of the sperm
Yeah.
aligned properly. So we should
Yes.
not, we should not just count it. So uneven pronuclei, non-aligned pronuclei, and what about the nucleolar precursor body?
Nuclear precursor bodies, we've seen that either, they are polarized in both the PNs or they are spread in both the PNs. Then that's a good sign.
Polarized at PN junction or scattered in both the
both,
PN?
yeah, in both, yes. Yeah.
Yes.
So that's a good sign, but something that we are now noticing in some of our embryos is two normal size PNs and one micro pronuclei. And these are embryos that we are again separating from the others. And we have been trying to follow the growth of these embryos to see how well they grow further. And it's very interesting because we found papers where they said that most of these embryos, even though we classify them as 3PN, but they grow into good embryos, and they've been found to be diploid. So that's very interesting in terms of PN.
Transfer those.
No, not as a first choice.
The chromosomal status is okay.
Not as a first choice. Never as a first choice.
There is no other.
If there is. Yes.
So, Gaurav, if there is a single PN, what may be the causes? What may be the other causes of it?
It's because the appearance or the disappearance of the PNs, they are asynchronous at most times. So it could be just a 2PN embryo where one PN has appeared first or disappeared first, and we are looking at it at a time point where it looks to be one PN. But otherwise, it's a parthenogenetic activation of the oocyte. So if it really is one PN in reality, then it will not grow any further. It will show very poor embryo quality.
And if there is no PN at all?
Again, we might have missed the PNs, they might be early, they might be moving early, and probably we'll catch them. So it happens where sometimes we see 0 PNs in none of the zygotes. And that's probably because either we did an early ICSI and we came in late to look at the embryos the next day, or and so we never declare a fertilization failure on day 1 morning. We never do that. Even if we don't see any PNs, we might see polar bodies. And so we always wait till day 2 to confirm that there is 0 cleavage, and then only declare fertilization failure.
If 2 polar bodies are there, then we can consider, we can check.
Definitely.
And if not 2 PN, there may be 3 PN, 4 PN, etc. There are few study about the removal of the pronuclei by micromanipulation or addition of 1 PN when there is 1 PN already exists in it. You have any opinion? We can just practice, or it is not?
No, we'd rather just separate them, segregate them, and because these are all good research questions, but in the clinical setting, they're very risky.
We should not. But there are few papers. Just we can show you. Yes.
So just a quick query, Dr. Gaurav. So for those ones which you said you have the 2 normal PN and 1 micro PN which you observed, did you do PGS, and what was your finding? They were all diploid, or was there some?
No, so I haven't done PGS, but I have made many blastocysts out of such embryos where the 3rd PN was a micro PN.
Okay.
And there's a gentleman by the name of Antonio Capalbo, and they have done PGS on 200 such embryos which had a micro PN, and they found that 85% of those blastocysts were diploid, were normal.
This is something worth considering if you don't have.
Yes, so that gives us confidence that if there is no choice, then we can, after patient counseling, we can consider these embryos for transfer.
Transfer, yeah. There is another paper also. Next one.
Yes. So here again, ma'am. So if you look at that, whether it's 2 PN or 0 PN or even 1 PN, with PGS, with PGS, these are embryos which can be considered.
Yes. If there is no other way. And Gaurav, you know that we should consider the zygote when there is another paper about abnormally fertilized oocyte can result in health.
Yeah. So I was just mentioning this paper, ma'am. So ma'am, I was just mentioning this very paper of Capalbo. Yeah.
In your experience, have you ever inseminated, you done an ICSI with one sperm, Dr. Charu and Dr. Ved, and on the day of fertilization check, you found a 3 PN or something, contrasting to your method of working?
Many times.
Many times we have seen that but I think sometime sometime when we are injecting and the little bit PVP, extra PVP is left over there. So next day you see that time you can see that it look like third PN. So maybe this can be one region, and sometimes it is abnormally fertilized. Thank you. What up, Charu? Can you elaborate something else, or Gaurav?
Yeah. That's one reason why we have to do the PN check, whether it's IVF or ICSI, because you don't want to miss out on the embryos where the second polar body has been retained. So it's absolutely imperative to do fertilization check. We don't do other checks. We don't do syngamy and all of that. But fertilization check is a compulsory thing.
And many times it is also seen that they are superimposed, both PNs. So although there are 2 PNs, but they looks like a single PN. And then you have to be very careful in observing also. And I think this also eliminates the pathogenic development, because sometimes it happens that if you miss the PN and you see 2Cl, you never come to know that this is a normal cleaved embryo or a pathogenic embryo if you have not seen the PN.
Yes.
Sir, if you have a group of embryos where some are at 2 PN stage and some don't show any PN, like it's a 0 PN, do you segregate them for the purpose of transfer? Dr. Yusuf, what's your opinion?
If we have no choice, if we don't have any other embryos, we counsel the patients and we advise them to do PGS. And if the result is normal, we can transfer the embryos. We had many cases with 0 PN, 1 PN, and multiple PNs that showed normal PGS. And after the transfer, when the patient is pregnant, we do the non-invasive prenatal testing from the blood for the chromosomes, and we confirm the result that the embryo is normal. But for all the patients we did that were abnormal fertilization and normal PGS result, all resulted in normal pregnancy and normal live birth.
Sometimes the difference in the nuclear precursor body in 2 PN is more than 3. In one it is more, in another it is less. What will you do? You will check the chromosomal status later on?
Yes, if we have any doubt about the fertilization and we don't have any other choice, like if we have only this embryo for a transfer, we counsel the patient for doing the pre-implantation genetic screening for 24 chromosomes. And as I said earlier, most of them have a normal chromosomal component.
Okay. So now it is the early cleavage. I think, Taranjit, now I can transfer my responsibility to you.
Okay,
I
ma'am.
asked so many questions, and you can now, it is your turn, please.
Thank you. Thank you, ma'am. So, Dr. Charu, as a routine, before also you have told that you identify early cleavers.
Yeah.
At what time post insemination, and what is the significance of identifying early cleavers?
Yeah, it is mostly done on after 22 hours to 24 hours post insemination. Maximum we can wait till 26 hours. It depends on the maturation development of the embryo. The importance of observing this is that if you see a very good PN, but if you don't see a cleavage on time, that means this may be a slow growing embryo and you should be culturing it in a separate drop, or you can isolate it from the other embryos. And as I said earlier also, that cleavage pattern we need to follow. If we are seeing cleavage with a equal blastomere or good quality embryo, we can just select that, okay, this embryo is growing with the normal speed, so this can be selected for the normal, for the transfer. And another thing I was just wondering to ask, that if someone, many times I've been asked this, that if we miss the PN stage observation, then what we should do? How we can come to know that whether fertilization is there or not? So I think the probable answer is this, that if you see for early cleavage, you probably come to know that this is fertilized properly. Although 3PN possibility is not omitted, but at least you can say that, okay, because it is cleaved on time, so it might be fertilized.
So many a times at the time of FERT check, no, it's not very common, but at the time of FERT check, we do see a two-cell embryo dividing.
Yeah. That is another important aspect of it, that in particularly IVF cases, when you denude them for PN observation and you see there are cleavage in the already some of them. So this cleavage is definitely a pathogenic development, because at 18 hours we cannot expect a 3 or 4 cell, and even if they are normally divided, these embryos cannot be taken for transfer because they are not in synchronous with the cycle. What they are supposed to be at PN, and they are already at 4 cell. So these embryos we have to omit. So this is the importance of PN check. PN check you should do at any time, at any cost. You have to be observing PNs.
Okay. Sir, would you like to add anything, Dr. Yusuf? Do you identify early cleavers?
In our practice, we have been using time-lapse incubation since 2012. And we observe the early cleavage. Like we consider it as a positive sign when it happens for pregnancy. And there are many papers in the literature that support this finding. So when we have an early cleavage embryo and it continues to grow to the blastocyst stage, we give it the priority for embryo transfer.
Okay. Okay, Dr. Yusuf, next question is for you. What are the important parameters for grading cleavage stage embryos, and in what order?
When we talk about a cleavage stage embryo, usually it is up to day 3. For the cleavage stage embryo, the important things are the correct timing of morphological changes. So we need to have the 2 pronuclei appear at the correct time. Like late appearance of pronuclei, this considered as a negative sign. And we need to look at the symmetry of the blastomeres and the number of blastomeres in relation to the insemination time. And we need to look at the multinucleation. We exclude the embryos who have multinucleated blastomeres. And we look at the percent and location of fragmentation. As we all know, fragmentation is associated, when fragmentation is very high, it's associated with poor blastocyst formation and poor implantation. So these are the main things for embryo grading, like the timing, number of blastomeres and their symmetry, and presence and absence of fragmentation.
Which criteria takes the priority in your opinion?
We give a priority for the embryo that has no fragmentation and normally cleavage, like fast cleaving embryo like for example 10 or 12 cell stage is excluded, and slow cleaving embryo also are excluded. So the priority is for embryos that has symmetrical blastomeres, no multinucleated blastomeres, and less fragmentation for transfer.
Which growth parameter most accurately predicts blastulation rates after grading day 3 embryos? Dr. Yusuf?
When we look back at the time-lapse movies we see, like we learned a lot from time-lapse. So it takes picture every 7 minutes from the minute of insemination till the transfer or freezing. So the time-lapse showed us that when the time difference between between a progression from 2 cell stage to 3 cell stage is very less or very long, this means the embryo will have low chance to reach the blastocyst stage. And when the time difference between the 3 cell stage and 4 cell stage is more than 2 hours, this is considered a negative correlation. And when the time difference between 5 stage to 8 cell stage is less than 8.8 hours, so this is considered a good correlation. These 3 criteria can help us to predict which embryo will reach the blastocyst stage. It's not 100% accurate, but it gives like more prediction chances for the embryos than the others.
Sir, these are time-lapse indicators. Unfortunately, we are from India and not many labs have time-lapse. So Gaurav and Charu, in your opinion, which parameters would you be looking at for blastulation?
Yeah, I think we mostly look for the blastomere distribution, its pattern, its size, and even 10% fragmentation is also there. We can consider it because many times it has been seen that at the time of observation there are this is seen, but later on when the embryo is fully formed, we hardly see any fragmentation there on day 3. So blastomere morphology is, I think, still the best criteria. Blastomere morphology, number of blastomeres, its cleavage pattern, that is the gives us the best idea about probability of blastocyst formation.
Sorry, there is some problem in the connection, I think.
Yeah.
You were saying something.
I was saying that the cleavage pattern, the size and shape of the blastomere, number of blastomere, these are the few criteria which we will follow for probability of developing and blastocyst for an embryo, day 3 embryo. That is most common practice in our India. The places where the time lapse is not available, this is the best possible way to predict.
Gaurav, what is your opinion? Because if you are going to extend the culture, then you have to look for certain factors in grade 3 embryos.
It's a crucial decision whether to to be able to estimate whether the embryos on day 3, do you think they will go on to make blastocyst or not. So for us in our practice, the most important thing is the cell number. We don't give a lot of importance to fragmentation. Slight amount of fragmentation is okay. We don't look at it. But for us, the most important criteria is the number on day 3. So if there are 6 cells or 5 cells, then it's definitely slow. So we at least want a 7-cell embryo, and from 8 to 10 or 11 cells is okay.
When
it goes above 12 cells,
can you call me after 1 hour? I am in a
when
meeting,
it goes
please.
above 12 cells, then we think that it's a fast cleaver. Nowadays we see so many embryos which are undergoing compaction on day 3, and where already they're almost looking a bit like a morula, or they've begun compaction. So
in single step media.
Yeah. So we see that a lot. There was a time when we used to think that fast cleaving embryos are bad and they will not make, but now we know that all these embryos make blastocysts. All these fast cleavers make blastocysts.
True. So we'll move on to the next question now. Dr. Yusuf, what do you understand by state-specific and non-state specific embryos, and what is the relevance?
In IVF, we are trying to choose the best embryo for transfer. The stage-specific embryos are the embryos that have symmetrical blastomeres and correct number of blastomeres at the expected time intervals. The non-specific, the blastomeres are not specific, are not symmetrical, and there is a noticeable difference in the number of blastomere. And for the stage-specific embryos are usually classified as the top quality embryos if there is no fragmentation, and the non-stage specific are considered the second best if there is no fragmentation and the number of cells is correct to the time of insemination. And they are the non-specific. They are considered like the second best also for implantation. Like some studies classified the non-specific as grade 2 or second best, and they have sometimes they have same implantation rate as the stage-specific, and other studies showed they have less implantation rate. But also one more factor is the presence or absence of a fragmentation. In my opinion, if it is non-stage specific and no fragmentation, it will have the same implantation rate as stage specific.
So given a choice, if you have a state-specific 7-cell embryo versus a non-state-specific 14-cell embryo, which one will you choose for a day 3 transfer?
If it's day 3, I will choose a 7-cell embryo. The non-stage specific 7-cell embryo.
and stage-specific 7 versus a stage-specific 8 with fragmentation, with 20% fragmentation?
I think fragmentation is considered as exclusion criteria for a transfer. So I would choose the seven cell stage non-specific over the 8 cell stage specific with 20% fragmentation.
All right. Moving on to the next question. In your experience, what is more important, embryo fragmentation versus cell symmetry? Dr. Yusuf.
The embryo fragmentation is considered as exclusion criteria for embryo selection, and the embryo symmetry are considered as inclusion and as inclusion criteria. The publication classify fragmentation into 5 categories. Number 1, type 1 fragmentation has very few percent of the fragmentation and associated with 1 blastomere. The type 2 fragmentation is a small localized fragmentation associated with 1 or 2 blastomeres. And these are still acceptable types of fragmentation. Usually it's less than 10%. The type 3 fragmentation, it has a small fragmentation. It's scattered through all the embryos, through multiple blastomeres. And this affects many blastomeres as considered as negative selection criteria, and it affects the implantation and the blastocyst formation. Type 4 fragmentation is large fragmentation and scattered associated with several blastomeres and uneven blastomere number. The number 5 is the worst, and I think like only a few pregnancies might happen from this, which has a lot of fragmentation and cause cell compaction. And this picture, we can see this on the left down, type 2. It's associated with few blastomeres. And type 3 is associated with many blastomeres, but still less fragmentation. We have some healthy blastomeres. And type 4 in the picture right down is bad fragmentation. It all involves most of the blastomeres. So when we select embryo for a transfer, we give a priority to embryos that do not have a fragmentation or less fragmentation, and the number of cells. So number 1, the first criteria is to have good number of blastomeres, like hopefully 8 cell stage on day 3. With no fragmentation. This is the best embryo. And when we have fragmentation, we try to choose the embryo with less fragmentation. Like the first option is symmetrical or slightly asymmetrical embryos with 8 cell stage with 0 or type 1 fragmentation. Second is asymmetrical embryo with 8 cell stage with 0 or type 1 fragmentation. And the third option is symmetrical or asymmetrical embryos with the fragmentation. So we give a priority for the embryos with no fragmentation and 8 cell stage.
So, given a choice, you have to choose between a 8 cell stage specific embryo with scattered fragmentation versus a 8 cell embryo with localized fragmentation. Which in your experience is better, because you are running time lapse also on that?
I think the localized fragmentation have a better chance for blastulation because it affects only 1 or 2 blastomeres. The scattered fragmentation can affect a lot of blastomeres and will result in less blastocyst formation.
True. So the audience has to take this message that localized fragmentation is considered absorbable, and and scattered fragmentation is considered to be associated with aneuploidies also. So research has shown. So prefer transferring embryos with localized fragmentation.
Yes, that's it.
This is the consensus grading which we have shown. A day 2 embryo should be 4-cell, mononucleated, 3D tetrahedral arrangement with less than 10% fragmentation, whereas a day 3 embryo observed around 68 hours should be 8-cell, mononucleated, and again less than 10% fragmentation. The cell size should be stage specific. Any multinucleation or non-stage specific blastomeres or more than 25% fragmentation render it a grade 3 embryo, should be excluded from transfer. So, sir, I'm giving you the choice of 3 embryos. It's for everybody. So, which one will you like to transfer? You have to choose 2 embryos in these. They are day 2 embryos. You have to transfer on day 2. Which amongst these 3 will you choose? 2 of these. Dr. Ved? Gaurav, are you there?
I'm there. I'm there.
Which one will you choose, Gaurav, amongst these 3? Given
We
a
have
choice.
choose 1 or choose 2. So they are all. So the middle one has, I think it appears to have 6 cells. So probably, and but the shape is, I think it's been compressed. It seems to be compressed. So in my opinion, the third one, since each blastomere appears to have a single nucleus, so that is important. And
my connection was actually, I got disconnected. Can you please tell me again which one will you like to choose?
Yes. So if the third embryo out of these 3, where each blastomere appears to have a single nucleus, so that looks good. I think that all of them have a single nucleus, and then the first embryo, which seems to have 4 equal size cells, and there's a localized fragmentation. Probably the 5th cell has fragmented. The middle embryo has about 6 cells, but it looks kind of compressed.
It's 5 cells.
5 cells, okay.
The noteworthy point in the middle embryo is that all the blastomeres are equal, so it's not a stage-specific embryo.
Yeah. So the only stage-specific embryo is the third embryo. The third embryo is the stage-specific.
First choice.
Embryo.
Third embryo is the first choice, and then first one is second choice.
Okay. Dr. Yusuf, do you have any different opinion?
I agree with that.
So we'll move on to the next question now. This question is for Dr. Ved. Is early compaction a good sign? So we have been discussing a lot about early cleavers and with new age media, cells progressing fast and precocious kind of growth. So is early compaction a good sign, Dr. Ved?
Yeah, that early compaction is a good sign. Actually, there are some paper here I want to show that. And of course, Istanbul consensus, it was noted in that while early compaction on day 3 is atypical, this observation is of unknown biological significance. But in 2006, there is one paper in fertility sterility where they shows that compaction grading was strongly associated with implantation potential. However, the direction of this effect depends on the degree of fragmentation. So assessing the degree of compaction can be valuable addition to traditional morphological assessment in identifying optimal embryo for day 3 transfer on day 3. And there is second paper in 2013 in JAR, where they showed that early compaction seems linked with the ovarian response to stimulation and embryonic quality. The pregnancy rate is significantly increased when the embryonic cohort contains at least one compacted embryo, and when at least one compacted embryo is transferred. There is conclusion that early compaction, sometime observed at day 3, may serve as a useful additional criteria for selecting the embryo transfer. So I think we are also in our routine practice. What I am doing on day 3, if embryo is compacted, so I try to transfer out that embryo and one stage specific embryo on day 3. What I am doing in my practice.
The important point here is that early compaction is linked with ovarian response to stimulation, and so that is an important thing. If the stimulation is good, then you might expect some blast. In my practice, I have seen, I'm working in a center, and those guys have excellent pregnancy rates, and I mean all the rates are good. So in that center, I always get grade 3 compaction in most of the embryos. So I don't know how to deselect, because if you have a cutoff of 12 cell embryo on day 3, and unfortunately or coincidentally you have all the embryos which are showing 14 cell or 16 cell with some signs of compaction. So I'm in an FX, I'm in a tizzy that which one I need to choose. So Gaurav, what is your opinion on that? If you have all the embryos are precocious, they're fast growing, with signs of compaction or without signs of compaction, which one will you choose? I mean, the slow growing ones, comparatively slow growing ones, or with compaction?
We will first not choose them on day 3. We will just culture them to day 5. If we have many embryos which are seeming like as if they've compacted. But for us, we will choose embryos which look to have relatively fewer cells. So in our practice, in our opinion, what we follow is that if we have a 8 to 10 cell embryo, which seems to have begun compaction, that is better than a full-fledged morula or a embryo which seems to have too many cells. So we like to choose an embryo which has 8 to 10 cells, and then you can see junctions and cell junctions between cells. So we think that is probably better.
So in your opinion, the cells which are compacting and showing a higher cell number on day 3, do they form a blastocyst early or on day 5 itself?
No, so they are the ones which will tend to form a full blastocyst on day 5 morning. Because on day 5, on the morning of day 5, we don't find all blastocysts to be fully expanded blastocysts. Most of the blastocysts are at the grade 3 expansion stage, but these are the ones which are likely to be at grade 4 or sometimes even grade 5 stage.
So what would be your choice? Would you transfer these embryos, or would you simply preserve them or take them for PGS and check for any query?
No, we'll transfer them.
But on day 3, you are extending them.
On day 3, we are extending them so that we see them as blastocysts on day 5, and we'll definitely transfer them.
Okay. So, Dr. Charu, would you like to add something? Because you're a freelancer, you are going on day 3, you're not going to wait till day 5. So what will be your opinion?
Till now in my practice, I prefer to do day 3 transfer only. But if we see a very good compacting embryo, early compacting, not fully compacting embryo, maybe on day 3 is too early.
Yes.
So definitely we will culture him for the blastocyst, and we will select out from the blastocyst which is the best one.
That's a very important point, that we don't like to see full compaction on day 3. That is something which is not a good sign. So early compaction is what we're looking for, not full compaction.
No, you are right. You are right. Absolutely right.
So we will deselect those embryos which are completely fully compacted.
They may be the fast growing embryos as per our criteria.
And they may also not form blastocysts. Many times we have seen that embryos which are going a bit too further than the others, which are almost like 24 hours ahead of the other embryos, they fail to form blastocysts.
So this question is for Charu. At what stage should we look for multinucleation, and why is it important?
Yeah, it is usually observed at day 2 or day 3 embryo, and it is very important in the, as it gives us idea about the genetic status of that embryo. If you see multinucleation, definitely this embryo you need to observe minutely. Maybe if you have the facility of PGS and all doing, you should go for that, because multinucleation is, I think, the most important and very first sign of genetic abnormality in an embryo. Mostly day 2 or day 3, it gives a fair enough idea of multinucleation. Each cell, you can see it. So even if you see the abnormality is like fragmentation is there, or means usually I saw that after day 3 you will not be able to differentiate. It's mostly on day 2 or day 3, and it is very important.
So multinucleated embryos should be excluded from transfer because
definitely excluded.
Another consideration also should be the number of cells which are showing the multinucleation.
Yeah.
So that is also an important thing.
A very important point he has brought up. Yeah. So Sam, what is your opinion? Have you done any genetic analysis on multinucleated embryos?
So when you are seeing, generally what you see is in multinucleated embryos, if there are only one cell or a few cells showing the multinucleation, then you do have a better outcome in terms of the embryo ploidy. But if multiple ones are showing it, so essentially the more number of cells showing multinucleation, the poorer the outcome. So that would be the one of the important things to look at when you're looking at multinucleated embryos.
So what Sam
definitely is lower rate, lower birth rate, as the literature is also showing on screen. Generally, that impact is there. So these are not going to be first choice for anything.
But you know, it's hard to, Sarapit, it's very hard to look for multinucleation in a 10-cell embryo or 12-cell embryo.
You have to, it's either a 2-cell stage or maximum 4-cell stage. You know?
Yes. So on day 3, it is not practical to talk about multinucleation and number of cells with multinucleation. What you can see is uneven, sizes, and those will tend to be multinucleated mostly. But otherwise, multinucleation on day 3, I don't think we ever look for multinucleation on day 3.
I agree with you, Dr. Gaurav. We're not talking about a day 3 because there, like you said, the sheer number of cells that would become progressively difficult because the number of cells are going up over there. But what you're talking about in a day 2 or a day 4, there again, because if you're seeing all the 4 cells showing it, then obviously the outcome is going to be much more poorer. If you're seeing one cell, then there's a possibility that the embryo will progress and there will be some correction possible.
Yeah.
I think with the new age medias and improved culture conditions, we are seeing more, less and less of multinucleation.
Yeah. But I'd like to make a point here that we're talking about early cleavage and multinucleation and all of this in day 2 embryos or PN scoring. It's all of this will only be useful if we are culturing embryos individually, singly, to be able to trace them. So for a lab like mine where we are doing group culture, it is basically has no significance at all looking at early cleavage or multinucleation because we are doing group culture. So if anyone wants to invest time into looking at these features, it's very important to start culturing embryos individually, because otherwise you will not know which embryo to reselect and which to select later on.
If we culture in multi-well petri dish and we can chase each and every embryo possible. And 3 important things actually from my 30 years experience: uneven blastomere on day 2, multinucleation on 4-cell stage, and abrupt division from 1 cell to 3 or 5. These 3 things actually matters more. But to chase each and every embryo, we should culture in multi-well petri dish, juicy petri dish.
Right.
Oh, I think Sarabpreet
Sarabpreet,
lost.
unmute.
Sarabpreet lost his connection. Did he?
No, now he's back. Now he's back.
Yeah, I think sharing the screen again. I'm sorry for the poor connection.
No problem.
Yeah. Sorry, Gaurav, can you please come again because I'm extremely sorry. Connection is poor. I don't know why.
No, so I was just making a point that in order to look at multinucleation or even events early on, like early cleavage or doing a zygote score or any of that, it is very important to individually culture each embryo for the sake of traceability. Because in a lab like mine, we do group culture. And so in group culture, none of this has any meaning. No amount of looking for multinucleation or early cleavage is going to help because all the embryos are, in a group.
You can always segregate those embryos, in a different dish, maybe in drops.
Yeah, then it requires a lot of segregation at every different point. So that's
these
what.
things are not very common. I mean, multinucleation, how often do you see them?
Yeah. So I just wanted to make a point that they have to be segregated, for you
to be segregated, and additional dishes are always to be made, just for the purpose of segregation. You can't just do the whole case in one dish of single step media. So now we move on to the next question. Lost it. So Sam, would you like to give your inputs about multinucleation?
So we did have a discussion about that, at what stage we're looking at it, and the number of cells which are showing that, because as the embryo progresses and develops further, this is something which becomes progressively more and more difficult to detect with the number of cells increasing. So like I said, at the first cell stage, you can have if you're looking for multinucleation there, you can see the number of the cells which are showing the multinucleation. That is a very important fact to look at.
The article which you have quoted is that it says that most multinucleated embryos have the capacity for self.
Yeah, they do. But if you look at a first cell stage and all 4 of them are showing multinucleation, then the likelihood of self-correction would come down there.
Yeah, I agree.
That's what happens.
Yeah.
So it is not just looking at multinucleation, but how many of those cells are actually showing it is quite important.
The next question is for Dr. Ved. What is the criteria for selecting day for embryos? Dr. Ved.
So yes. So there is Istanbul consensus regarding the scoring of this day for embryo. So there are 3 grades where it is depend on the cleavage started or not. In grade 1, the whole embryo is involved in the compaction. All the cells are compacted. And in second grade, yes, cleavage is started, but involved majority of embryo. There is some cells are out of that. And in grade 3, the 4th stage, cleavage stage is not started plus minus, where dysphosphonated compaction involving less than half of the embryo with 2-3 cells remaining as discrete blastomeres. This is the criteria we generally follow for the day 4 selection. But here I want to mention that generally we are not doing so much day 4 selection, because on day 3 we select the embryo if we culture them further. Otherwise, we are not taking them out as a routine if we are not going to do the day 5 transfer.
So, Dr. Ved, if it's a Sunday on day 5, and how often would you do a day 4 transfer on a Saturday or something? Maybe a gazetted holiday next day.
Yeah. Not regularly, but sometime we are doing, and we are getting result also out of that. So there is one paper as shown in screen in 2018, where they showed that pregnancy rate and live birth rate were compatible as between morula embryo transfer and blastocyst embryo transfer. The implantation rate is 36.3 versus 39.6 respectively, and clinical pregnancy rate is 49.5% versus 51.9%, and live birth rate is 42.1% versus 45.6% respectively. Where statistically insignificant between group, the term birth rate was statistically higher in the MET group or morula embryo transfer group, and the blastocyst in the blastocyst embryo transfer group is 95.7% versus 79.5% respectively.
So you mean transferring is a good option?
Yeah. You can transfer on day 4 also.
Dr. Yusuf, what is your opinion?
Yes.
Dr. Yusuf, what is your opinion? Do you routinely transfer day 4 embryos?
No, we do it rarely.
Because yours is PGS, all PGS kind of.
Usually we do day 5 transfer, but maybe like we do it once or twice a month, like 2 out of 300 cases. That is, it might be associated with day 3 biopsy and day 4 transfer. So PGS is done on day 3 and the transfer is done on day 4. And this happens only in rare occasions when like the patient cannot come on day 5 or the patient requests a certain physician to do the transfer and the patient is not available on that day. But this is our current practice. But a few years back, we used to do day 3 biopsy and PGD and day 4 transfer. And we found that at that time, day 4 transfer is has the same pregnancy rate as day 3 transfer. And we presented this paper in the AB conference in the USA in Las Vegas, like in 2012 or 2013. But now we like it's very rare practice, like once or twice a month.
Yeah, right. That's what we are doing.
Gaurav, what is your protocol? Would you transfer day 4 on day 4 embryos, or?
No, we generally never transfer day 4 embryos.
So what is the reason behind it not transferring day 4 embryos?
Nothing, because we are so close to day 5. Why, if we made the effort to go beyond day 3, then we feel it's important to see because there's a lot more information that we get on day 5 and day 6 regarding specifics of the embryo as compared to just looking at compaction on day 4. So we feel that day 5 is more useful.
But generally, good morulas on day 4, generally they will convert into day 5, good day 5 embryos.
Yeah, but not all of them. So, and there are many more features that we are looking for in the embryo on day 5.
Recent literature, it's quite in favor of transferring as well as freezing day 4 embryos.
Okay, we have no experience with freezing nor transfer of day 4 embryos.
Okay, Dr. Ved, would you like to tell us about day 4 freezing?
Yeah, there is one paper, and sometime I have also done freezing on day 4, and they are equally good. There is no problem with survival rate also. And this paper is from RBM, Reproductive Biomedical Endocrinology in 2019. They concluded that the post-hope blastocyst formation rate was satisfactory, with approximately 1/2 of heavily fragmented morulas developing into blastocysts. Most of the poor quality morula were to freeze with the reasonable goal of obtaining pregnancy and a live birth rate. So here they are showing that they are equally good, although there is little bit low pregnancy rate, but they are equally good to transfer, and you can get better blastocyst also.
So, Dr. Yusuf, in your opinion, would it be wise if you get morulas on day 5? Will you freeze on day 5, or will you extend them to day 6 and then
We usually extend them to day 6 or sometimes to day 7 and do freezing and transfer in next cycle. And when we go retrospectively to our statistics and practice, we found that day 6 blastocyst has the same implantation potential as the day 5 blastocyst. And some publication or some recent publications support our finding.
What of you would like to contribute?
Yeah, so I wanted to say there's a huge difference between a morula on day 4 and day 5. So if we are discussing a morula on day 5, we already know that the embryo is lagging by a day. And so it is very important to see how it grows further, because all morulas on day 5 will not grow on to become a blastocyst. So it is very important to establish that the embryo is competent before we freeze it. So I think freezing a morula on day 5 is not going to help at all. On day 4 is a different story. I thought you mentioned that day 4 morula freezing and transfer.
We are discussing both actually.
But day 5
mentioned about day 5 morulas. So
day 5 morulas, we will always we will culture them further.
Okay. So this question is for you, Gaurav. What are the important parameters for grading blastocyst stage embryos, and again in what order?
All right. So here, first, because you've asked the preference, our first preference is to look at the developmental rate of the embryo. For us, that is the most important thing. So which is depicted by the expansion score of the embryo. Again, because we are constantly discussing the speed of embryo development. So we want to see embryo which has formed a full blastocyst on day 5 and so on and so forth. And next comes the quality of the embryo itself, where in a blastocyst, we are looking at the number of trophectodermal cells and the size of the ICM. So this is the sequence in which we look at the score.
Okay, would you like to elaborate on the degree of expansion, the gradings?
Yeah. So as you can see, this is probably the Istanbul grading, which has been adopted, and not the Gardner grading. So here, as you can see, the second blastocyst is a fully developed blastocyst, where there's you can see the inner cell mass and the trophectodermal layer. However, the zona is maintaining its original size. Whereas in the third embryo, which is the grade 3 expanded, the zona has thinned down. And the definition of expanded blastocyst is one where the zona has reduced by 50% of its original thickness. And whereas the first embryo is an early blastocyst, where yet you can see that the proper demarcation of the ICM and the trophectoderm hasn't occurred. And obviously the fourth set of embryos, they are the hatching blastocysts, where you can see a small amount of trophectoderm herniating out at 3 p.m. of the first embryo, and the other embryo at 6 or 7 p.m. has a wide hatching area, and the third embryo is a fully hatched blastocyst. So I think according to the Istanbul consensus, they're all graded 4.
Yeah, they've clubbed the A and B of Gardner and E and F of Gardner into single grades.
So we use the Gardner scoring system.
Basically the same, and Gardner is actually simpler.
Okay.
So inner cell mass, again, your opinion on the grading of inner cell mass?
Yes, so in the first picture on the top left, the inner cell mass looks sufficient and big with many cells, whereas in the second image, it's much smaller comparatively. So that's something which could be graded as B, whereas the first one, it can be graded as A. And in the third image, it's hard to see the inner cell mass. So that's inner cell mass, which receives the grade C. And here in the trophectoderm, as you can see, the first image on the top left, that has a very, very good trophectodermal layer, which is evident from the multiple spherical cells, you can see that it's all busily packed, tightly packed. Whereas in the second image, there are fewer cells. So this is again a subjective evaluation, but with time, you can get a lot of uniformity in grading these embryos, and they have to be graded while constantly rotating them three-dimensionally to be able to see every part of the embryo of the sphere. And the third embryo, as you can see, there are areas at 11 o'clock and 1 to 3 where you can see completely bald areas with no cells and probably a little bit of degeneration. So this I would definitely, so I agree. This is a grade 3 trophectodon or a grade C trophectodon. So we grade them as C.
Okay, it's Istanbul's called Symbol.
Okay.
So what carries a higher, already you've answered this question. According to you, it is the trophectodon which carries more weightage.
Yes. So we look for a trophectodon, which is an embryo that is 4AB, where A is ICM and B is trophectodon. So that would be inferior than a 4BA for us. So we will first choose a 4BA as opposed to a 4AB.
So which amongst these two, which you see on the screen?
The second one.
What about this embryo? It has a decent trophectodon, which I'm showing now.
Okay.
Would you actually? This is a 4.
This is not a very good.
So would you discard this embryo or take it for PGS and look for?
No, so I would transfer this if this is the only embryo. I know that such embryos will be quite likely to be found as aneuploid on PGS. So if the patient is going in for PGS, so I will make a call looking at the number of cells. If I think that the number of cells is really low, then probably it will not even qualify for PGS.
This is a second or third embryo. Would you freeze this or would you let it go?
We would freeze it. Yeah, we would freeze it.
So at what stage would you like to transfer and freeze a blast? Gaurav?
Okay, so here again the decision is based on an interplay of the rate of development of the blastocyst, and two very important deciding factors are cell number and the degree of expansion. For us in our practice, this is the most important deciding factor. So I will break down my answer into since you've asked me the preference of stage for transfer and freezing. In a fresh cycle, we only transfer embryos on day 5. And we never transfer embryos on day 6 in fresh cycles. And there is a very, so this is a protocol that we follow in our laboratory, that in case we need to transfer slightly slow growing embryos. So on day 5 morning, if we have a full blastocyst, then it has equal opportunity to be transferred or frozen. However, if we see, which is very common, that an embryo is not a full blastocyst on day 5 morning. So in case if it is an early blastocyst, then we can still consider transferring it. However, if it is a morula, which means that it is probably a full 24 hours behind schedule, then we want to definitely take it to day 6 and then only consider freezing it. So we will never do a fresh transfer on day 6. However, in a frozen cycle, we do both day 5 as well as day 6. We know that for day 5 embryos in a frozen cycle, the clinical pregnancy rate in our center is about 10 percentage points higher than day 6 embryos, and the pregnancy loss rate is about 10 percentage points lower than a day 6 blastocyst. So this is my data from my center. So this is our preference.
So this you will ascribe to higher uterine receptivity in a FET cycle, or? or otherwise?
Probably a higher aneuploidy rate for the slower growing embryos, because there are a lot of papers which have actually said that there is no major difference between day 5 and day 6 blastocysts once the asynchrony is removed in the FET. But we have seen a significant, so 10 percentage points is not less, as far as clinical pregnancy rate is concerned and pregnancy loss rate is concerned. So if you combine both of them, then the difference between day 5 FET and day 6 FET results is, and I'm talking about ongoing pregnancy rates, I'm talking about 20 weeks of gestation, in our center is more than 15%.
Dr. Yusuf, would you like to differ on this?
We usually, in fresh cycles, we do day 5 only transfer. We don't do day 6. On frozen cycles, we can do, we can transfer blastocysts that frozen on day 6. And like suppose we have one blastocyst frozen on day 5 and the other frozen on day 6, and we need to choose one embryo, we give the priority to the embryo grading, to the higher embryo grade for transfer.
Irrespective of for day 5 or day 6?
Yes, yes.
Okay.
See, there was a recent paper, there was a recent meta-analysis which was published in Human Reproduction, where they looked at the clinical outcomes of day 5 versus day 6 embryos, both in fresh and frozen cycles. And where for the first time, they found out categorically that in both cases, day 5 embryos, irrespective of fresh or frozen, day 5 embryos were performing a little better than day 6 embryos.
Yeah, it has to, because anything right for the time has to perform better. So again, I give you a Gaurav, this question is for you. The embryologist comes in the morning on day 5 to find 3 expanded blastocysts. They decide to transfer one blast and freeze the other 2. So after 2 hours, when the embryologist comes again, he finds that the blast is collapsed. So what is your advice to him?
Which one of these has collapsed?
Froze this middle one has collapsed. The other C has frozen already.
Oh.
What is your advice to him?
And he wants to transfer this.
This was selected for transfer. One
okay.
on right and left were frozen. So now.
Okay. So ideally, if looking at the first 3 images, I would select the first embryo for transfer, because in my opinion, the
first embryo has been kept for culture, the third have been frozen. And he finds
we may see this as a normal occurrence for many blastocysts, where they contract completely and then expand, and this is a part of a hatching process that they undergo. And so this is actually a good sign that the embryo is contracting and then expanding. However, there are, as you can see, few cells are excluded in the embryo, which goes against the embryo. But this is sometimes we see with blastocysts, where they contract and then they expand again.
So if he has to transfer on the same day, what's your advice to him?
Then to stick to the original score of the embryo, which was seen in the morning.
Possible that you wait for some time and this re-expands and then he can transfer, or he can transfer the collapsed embryo itself?
Oh yes, we can transfer the collapsed embryo itself.
It doesn't make it.
We've done it many times, where right at the time of transfer, we see that the embryo is collapsed. So we don't wait at that time then.
So Dr. Yusuf, do you wait if blastocyst is collapsed, do you wait for it to expand, or do you?
I would recommend to wait for some time to see if it re-expand. If it doesn't, we will advise the physician to thaw one of the frozen embryos and transfer it. but it's usually it's the nature of the blastocyst to collapse and expand on day 5. So usually we wait and for some time and to check if it expands. Like we will go ahead for transfer.
Yeah, and Dr. Yusuf has the luxury of time lapse, so you can keep looking at your embryos.
Yes.
Correct.
Actually, at the time lapse, like if you look sometimes at the blastocyst at one specific point, you think it will never expand. But if you look like 30 minutes later, you find it like fully expanded.
The take-home message, I think, will be to tell the embryologist not to freeze till the transfer is done, because
Yeah. Usually we freeze only after the transfer.
Yeah, definitely.
So Gaurav, again, this question is for you and Yusuf. Morphological features which correlate with the ploidy status.
Well, there are many. As I mentioned earlier, where we think that degree of expansion and the quality of, and we have also published on this, where we've shown that the quality of trophectoderm and quality of ICM, they correlate positively with the euploidy rate. And this means that grade A TE has a higher chance of being euploid as compared to grade B or a grade C TE. And the same applies for the ICM.
What is the coefficient of correlation in such cases? I mean, then there is no point of doing a biopsy if you say that they correlate well with euploidy.
Yeah, they do, but if
correlation or
no. So, but grade C trophectoderms and grade C ICMs, they also have a definite percentage of euploid embryos.
Yeah, because previous question you said I'll freeze the 4BB one also, so it might turn to be euploid. So
yes, definitely. But as I was saying, that morphology is not the only factor which determines the ploidy status. So it is very important to first make sure that other confounding factors are not affecting the ploidy status, in which age is the most important. So when so a 5AA blastocyst in a 31-year-old and a 5AA blastocyst in a 42-year-old have huge difference in terms of euploidy rate. So confounding factors which are very important according to us is age. First thing is age. Second thing is if it is a patient of with etiology of translocation, where we know that despite the morphology, despite any amounts of A's and despite beautiful embryos, we know that 70 to 80% of the embryos will turn out to be aneuploid. Then whether it is the first transfer or whether it is the 5th transfer, that makes a huge difference. And how many good quality blastocysts there were, whether there were 10 good blastocysts for a patient vis-a-vis only 1 embryo for a patient. So these are factors which have an equal amount of impact on euploidy rate. And if you normalize for these factors, then definitely morphology, we know that a AA or a A grade will have a higher chance of euploidy as compared to a C grade.
So it has to be a comprehensive evaluation of patient factors as well as the embryo dynamics.
Yes, absolutely.
Dr. Yusuf, would you like to add something?
We tried to find a correlation between embryo morphology and ploidy status. We looked at many things, but we could not find like strong correlation. Sometimes we have bad quality, not bad, we cannot say bad quality, like for CC blastocyst, which has normal chromosomal contents, and 5AA blastocyst has abnormal content. And we looked also at the cleavage stage embryos, and we didn't find a strong correlation. So I think the morphology is not correlated to the ploid status. Even when we mentioned earlier at the start of this webinar that we have some embryos with with the 3 pronuclei and 1 pronuclei, and turn out to be at the end has a normal chromosome number and normal chromosome structure.
So in your opinion, we have to do a PGS and then verify, and all the other factors are
Yeah.
not there. I think we have discussed this, so we'll move on to the maybe the last question since time is also running out. So this question is for you, Sam. What are the clinical conditions in which you would?
Yep. So there are quite a few which have already been touched upon. I think Dr. Gaurav was speaking about one very recently, which is advanced maternal age, which is a very important indicator. You can also look at cases where you are having recurrent or repeated implantation failure. You have in some cases, male factor can be considered. And of course, when there is family history of, aneuploidies or some kind of monogenic heritable disorders, you can look at using PGTA or PGTM or PGS and PGD respectively. So these are the major ones. And of course, does it mean that, if the PGS is showing that it is euploid, it is 100% going to implant? No. Because I'm sure everybody on the panel here would have done the PGS, would have got a nice euploid embryo, and still it might not have implanted for various other factors. I think that is something which should be remembered when you're prescribing PGS or PG, especially PGS. PGD you're doing only when you know that the embryo is at a risk of becoming, affected for a particular disorder.
Sam,
that is something to keep in mind. Yeah. Yes, Dr. Sarapri.
Sam, in cases of high DFI, sperm aneuploidy is a separate aspect. High DFI generally is not a measure of aneuploidy; it's a measure of breaks in the chromosome.
Essentially, a measure of genetic. It's a measure of damage.
Yeah, how often do you see, aneuploidies in the embryos in cases of high DFI sperm samples?
So, in case of sperm samples with high DFI, compared to ones without that, we do see the PGS outcomes being more skewed towards aneuploidy. We do get cases of more aneuploidy in those cases. We do see it in our experience, of course.
And do you recommend any particular measure for DFI, or which methodology do you recommend for measuring?
So no, that there is no specific recommendation from our side for that. But in our experience, because what happens is once the DFI is done post ICSI, that's when we are getting the samples here. And once we see that, okay, this was there, and correlation between what our findings are, that more of the embryos turn out to be aneuploid in those cases. That is what is my observation.
Dr. Yusuf, which method are you measuring DFI in semen samples?
Sorry, I didn't tell you.
Are you measuring DNA fragmentation in semen samples?
Yes, we do. Usually we do it when we have a case with with the slow embryo cleavage, and with the patients with sometimes with early pregnancy loss, we do the DNA fragmentation test, but we don't do it routinely. Also, we do it with for the patient who have bad quality embryos.
Which method are you using for DFI?
Sorry?
Which method do you use to measure DFI?
Sarab, we are not able to hear you clearly.
We cannot hear you.
I said, I'm asking that which methodology do you follow for measuring DFI? Is it the sperm dispersion or flow cytometric, COMET or tunnel? Which method are you?
We send it to one of our hospitals, and usually they use the tunnel technique.
All right. So okay. Gaurav, are there any embryological indications and contraindications for PGT?
Okay. There are contraindications. I think we've spoken a lot about indications. So I can talk about the contraindications. So, like I said, that we believe that it is very important for an embryo to expand, and all embryos which do not expand and therefore have poor cell numbers, they don't do well in PGT purely for the reason of, because we need to perform an invasive biopsy in these embryos. And for embryos which fail to expand, it is incredibly hard to do a biopsy, and a lot of damage may get inflicted on an embryo. Then again, poor embryo quality is a major contraindication for PGT, where either there is very poor trophectoderm cell number, or in general the embryo is of poor quality. So such embryos will be at a very high risk of damage, because these embryos post biopsy also have to be frozen and then thawed. So the risk factor increases. Then single embryo might be a contraindication for PGT because many centers, they do not offer PGT for single embryos, and patients may change their mind because the cycle cancellation rate can get very, very high with single embryos. So yeah, these are all the embryological contraindications that I could think of.
Dr. Yusuf, would you like to add something?
Yes, usually the indications are patient related, and the PGD decision is taken by the physicians. But from our side as a scientist, we can recommend PGT when we have a patient with one embryo that resulted from a zygote that didn't show the pronuclei, or zygote with one pronuclei or three pronuclei. So we recommend for the physician to request the PGT. The contraindications is the low quality embryos and arrested embryos, and the embryos that do not survive after thawing or warming. When we are requested to perform biopsy and PGT for frozen embryos, usually we have a survival rate of 95% or more in our lab. But for the few embryos that do not survive, we cancel the biopsy and the PGT. These are the embryological contraindications.
All right. Moving on to the last question now. This question is primarily for Sam. And the question is, it goes like a consanguineous couple, male 39 years of age, woman 36 years of age. The child was beta thalassemia major. Only HPLC testing was done for parents and child. Both parents were seen to be carriers for beta thalassemia.
Okay.
Sam, would you recommend genetic testing for the parents?
Definitely. Since we don't have, since this is a case where you're looking for specific mutations, so definitely genetic testing has to be done for both the parents. And it can be done with a very simple test because the beta globin gene is quite small. So even with a Sanger test, you can do it. And since there is consanguinity, it's likely that it could be even a homozygous. I mean, they are head carriers, the child could be homozygous for that. So yes, they're found to be carriers. And the next thing here is, since we are looking at PGTM or PGD, we do a pre-PGD workup. So the important thing, what you want to do in a pre-PGD workup is that when you're working with the DNA from embryos, it's quite small quantity. It's in picograms. Your starting material is in picograms. So you do a process called whole genome amplification on this particular DNA, right? And for us, as geneticists, what we are doing, the embryo is an unknown. So we don't know whether the embryo has a mutation or not, or whether it's a carrier, whether it's homozygous. So you take two known cases, here the parents. You perform the same procedure what you would do for the embryo in terms of WGA, and then you validate that your primers or your Sanger, whatever test you're performing, can actually pick up this mutation in both. And then you have a ready set of primers for doing the PGD in the embryo. Okay, but for everyone on today's call, that is when you're doing some test like Sanger-based PGD. There are alternate methods as well. I'm sure Dr. Gaurav, because we had a discussion a few years back, and Dr. Gaurav and I, where we were talking about other techniques, but today we're talking about Sanger-based PGD, right?
Yeah.
So do I recommend only PGD or PGS and PGD? So one of the indicators in the earlier slide was AMA. So advanced maternal age is there. Yeah.
Sam, you have done the pre-PGD workup. Now
yes.
It's to go for an IVF cycle. 11 oocytes are retrieved. ICSI is done and 4 blastocysts are formed on day 5. So would you recommend a PGS plus PGD here, only PGD, since you have to rule out thalassemia only?
Correct, since we have to rule out thalassemia, but if you go to your previous slide, there is also advanced maternal age. So one of the strong indicators for doing it. So that I would strongly recommend doing PGS and PGD.
If the lady was 26 years of age in place of 36.
So even if the AMA was not there, and if it is possible for us to offer both, we would still recommend, because we're having an additional indicator for doing it. So very often in our experience, what happens, there are two approaches. One is in case we have clinicians who have asked us that you do PGS, and in euploid embryos you do PGD. And we have requests for the reverse as well. So even there, and I just quickly, just a couple of minutes, because although AMA is an important indicator for aneuploidy, last week I had a case of a 28-year-old woman who had IVF done, and she didn't come to us for PGS. She came to us for NIPT, and it was positive for Downs. So we have cases like that.
Yeah, but that's anecdotal.
That is anecdotal. Agreed. It's anecdotal. But we do have evidence for that.
Yeah, but that's anecdotal. So in a 26-year-old, we would not advise PGS. If the patient electively asks for it, then it's okay.
Yes,
but we will not advise that you need to get PGS done at all.
All right. So advanced maternal age is a very important criteria going by the discussion. And you do the PGS, 2 euploid embryos are found. PGD results are as follows: 2 euploid embryos, one is a carrier heterozygous and the other is negative for the mutation. So would you counsel the patient for a SCT, or would you transfer both embryos? Gaurav?
No, SCT, 100% SCT with the embryo which is negative for the mutation. There is no question for transferring 2 embryos where one is a carrier. So it is one by one. First embryo which is negative, and if God forbidding it does not work, then we transfer a carrier.
Dr. Yusuf, what's your opinion? Do you have
I tell you what we are doing in our center in such cases. These parents have previously affected embryo. So we do 3 tests. First, we do the PGS. And for the normal embryos, we do the thalassemia test and the HLA matching. And the purpose of that, the HLA, if one of the embryos is matching the affected embryo, this embryo can be used in the future for the treatment of the elder affected brother or sister.
Yeah.
So we would go for first, if the patient has we will give a priority to the PGS embryo, sorry, the normal PGS, which is HLA matching. Even if it's like a heterozygous carrier.
So you prefer to go by the HLA matching, and the carrier status is not that important.
Yeah. If HLA matching is not available or is not required, we'll first do in the first cycle, we'll go for the non-carrier. And if no pregnancy or after delivery, we will go for the carrier for the second cycle.
So this is all about the questions, and Sam would like to show this slide, which
yeah, so this actually we can go through it pretty quickly. It's essentially showing you that with PGS you have, of course, better pregnancy outcomes, and even Dr. Gaurav's data across the years shows similar things. This is This is, of course, Francesco Fiorentino's data, pretty old. He has updated data, and it's a similar thing. So there definitely is a role for PGS to be played and how it is to be applied as well. So I think that we have already touched upon. So you can see that without PGS versus with PGS, there is a an improvement in implantation and pregnancy rates. But like I said, it does not mean that it has to be blanketly prescribed. That is definitely there. Did we lose Sarabpreet again?
Yeah, I think.
Yeah.
He's back.
Yeah, he's back.
I lost my connection again. I was just asking Gaurav, which subgroup of patients did you include in this study? Because the pregnancy rates are significantly high.
Yeah. So this was initial days, and these were all. Now the whole thing has changed a lot. This was the time. This was a study that was predominantly done in 2014, when we were doing cleavage stage biopsies, when we had just started, and they were mostly there were a lot of cycle cancellations, and so these are rates which are given per embryo transfer and not per cycle started. So now the picture has changed quite a bit.
Okay, but were these patients poor prognosis patients, or what was the class of patients?
They were mixed.
Mixed.
They were all kinds. Okay. They were not just poor prognosis.
Okay, so we conclude the panel discussion now, and thank you so much, Dr. Ratna and all the panelists. Dr. Yusuf would like to shed some light on morphometric assessment of the embryo. Dr. Yusuf, over to you.
Yes, that was a study. I did it during my PhD. It was the idea of my professor, Professor Ja'far Ali. At that time, we did a lot of day 3 embryo transfer. So we looked at the morphological features of the embryos. We looked at mainly at the 3 things. First, the change of the zona pellucida thickness. Many studies were investigating the thickness of the zona pellucida at the time of embryo transfer. But in our study, we checked the thickness of the zona pellucida at the time of immediately after XC, and then we continue measuring the thickness of the zona pellucida till the time of embryo transfer. Second, we measure the volume of the cytoplasm and the volume of the perivitelline space. And we found that the zona pellucida thickness, the embryos that implanted has decreased in the zona pellucida thickness by around 32.7% at 70 hours after XC. And the average decrease in cytoplasm was around 20% at the time of the PN fading, and the increase in the perivitelline space volume was around 38%. So all the implanted embryos showed these features. It was done on up to day 3 embryos, but the main disadvantage of this technique, it requires a lot of time. Like you need to do a lot of measurements, and it takes several hours for one embryos to do the measurement. So we did recommendation for the companies who work on artificial intelligence to include this calculation on their program, in their programs. And we are trying to making potency out of this study.
Generally, the AI companies, generally they will evaluate blastocyst, usually. So this looks to be a good guideline if you can measure day 3 embryos, because ultimately the cumulative pregnancy rates for transferring day 3 blasts are much higher compared to transferring day 5 embryos. This looks to be a good guideline. Is any company going to develop this, Dr. Yusuf?
No, we did this using the embryoscope because it has some tools to measure the zona pellucida. It has a distance tool and it has the eclipse tool to measure the cytoplasm. We informed the company and recommended to include these features, but we haven't received any feedback, like any serious feedback from them. We got some promises, but no serious action has been taken till now.
Okay. Over to you, Dr. Ratna. If you can conclude. Dr. Ved, do we have any questions?
We have many questions, but I think we have no time left. It is already 7:31. So we have to conclude the session now. And Madam Ratna, want to say something, or I will conclude the.
You please come.
I have been replying to some of the questions on the chat.
Yeah, thank you. Actually, now there is no time left. Already 7:31 is happening, you know? So we have to conclude the session. So we both, Dr. Saraprit and I, would like to thank all the speakers and the panelists for making this program success. And a special thanks to Dr. Yusuf, our international faculty, who joined us today. And thanks to all participants who joined us. And I would like to thank Zygote Scoring for supporting this activity. A special thanks to Mr. Sudeep Mukherjee, who always ready to support academic activity. And I would like to thank Mr. Sandeep Jain and Sahana, who help us in this event. And very soon we are going to announce one more webinar in our banner iHera. So after 15 days, again, we will announce one webinar in this series. So over to Sahana, or Mr. Sudeep can take over.
Yes, sir. Actually, Sudeep sir will take over. Over to you, Sudeep.
Thank you, sir. Thanks for giving opportunity to us to host this wonderful program. It was although I could understand hardly 10% of it, but it was really interesting, really interactive, and we look forward to partner these sort of programs in future too. Special thanks to Dr. Ved Prakash and Dr. Saraprit Singh for coordinating the session so well. Good thanks to Dr. Rahul Sen, Dr. Paresh Makhwana, Dr. Ratna Chakravarti, Dr. Yusuf Alhu, who is our international faculty, Dr. Charudat Joshi, Dr. Gaurav Majumdar, and Dr. Sam Balu from Bangalore. Thanks all of you for your presence, all the esteemed faculty, and thank you very much for giving us this opportunity. We had a wonderful session. Thank you.
Thank you so much. Thank you.
Thank you so much.
Thank you. Bye-bye.
Thank you, sir.
Thank you.
Thank you, sir.
Bye-bye.
Thank you very much.
Thank you.